surgery, of course, it's minimal access. It has much lower morbidity, and is generally preferable if something's going to be done. But however, we are not saying that all of these lesions obviously need to be treated by an ESD, or that all of these lesions need to be treated at all. It is very important to have a discussion with the patients, weigh up all the treatment options, and then choose the right treatment modality. But if this is then employed as a treatment, then it frequently changes the diagnosis, and it has the potential to transform management. In that, the patients go from the uncertainty of having repeated endoscopies for an unknown diagnosis to, in the vast majority of cases, having the lesion completely removed and cured, and that stops unnecessary follow-up endoscopies. And then, as something that possibly we as endoscopists don't appreciate very much, is how much anxiety it causes the patients to be told that it's probably nothing worrying, but we'd still want to keep an eye on it very regularly just to see if it becomes worrying. So they say, why keep an eye on things if you're not worried? So there's a lot of anxiety with this, which this removes. And in the remaining cases, it is able to provide an accurate histological diagnosis and staging, based on which definite treatment plans can then be formulated. And thank you.
Thanks very much. We'll take questions while people are gathering themselves. Very clear presentation, thank you. You mentioned about endoscopic clearance. I didn't hear any mention of pathological clearance, but these are all not resections?
No, so the endoscopic clearance was initially at the time of endoscopy, but then when I looked at the recurrence data, when I said there was only one recurrence, that was including the histological diagnosis and the endoscopic thing at the... So when we perform follow-up, we look at it and we always take a biopsy from the resection site, just to ensure that there is no histological recurrence.
And technically, can you be very clear of the planes before you go into doing ASD? Because, I mean, some of these lesions are going to go into deep submucosa, or as you mentioned, one was touching muscularis.
Yeah. Yes, I mean, so you're asking about extension